Hello, everyone. Thank you so much for joining us for today's webinar, Be Fast If You Suspect a Stroke. My name is Debbie Durden. I'm a marketing consultant at Baylor Scott & White Health, and I will also be your moderator for today's call. As the largest not-for-profit healthcare system in Texas and one of the largest in the United States, Baylor Scott & White Health has a strong commitment to innovation, collaboration, integrity, and compassion for its patients. We are committed to educating our communities about the many ways we can help empower individuals to live healthier lives. Our legacy of providing quality, safe care has continued to propel us forward even during one of the most challenging times in our over 100-year history. So before we begin, I just want to let everyone know that if at any time during the presentation you have a question, if you'll just use the Q&A icon that's at the bottom of your screen to insert your question, we will answer those at the end during our Q&A session. So today's seminar will be presented by Dr. Rashedul Hasan. He's a board certified and fellowship trained vascular neurologist at Baylor Scott & White Health. And for over a decade, Dr. Hasan has provided his patients with personalized health and wellness through exemplary care, education, and research. He earned his medical degree from Sylhet Medical College in Bangladesh, and upon moving to the United States, he completed an internship in neurology at Mount Sinai in Queens, New York. This was followed by his residency in neurology at Texas Tech University's Health Sciences Center School of Medicine and a fellowship in cerebrovascular neurology and stroke at the UT Southwestern Medical Center in Dallas. Today, Dr. Hasan is a medical director for a comprehensive stroke center at one of Baylor Scott & White Health's facilities. This designation recognizes the medical center for having the staff, expertise, programs, and advanced tools necessary to provide rapid diagnosis and treatment of stroke, improve outcomes, and reduce brain damage in stroke patients. So, Dr. Hasan, with that said, when someone has a stroke, every minute that goes by reduces their chance for survival. And so what we know even before this call is that knowing the signs and symptoms of stroke and also having some sort of a basic plan are the things that are the keys that are going to help people survive. So can you talk us through what we can do if we or someone we know is suffering from a stroke?
Thank you, Debbie. I appreciate the kind introduction. Can everyone, I believe that everyone is hearing me okay. Debbie, you can hear me okay?
Yes, I can.
Thank you so much. Thank you, Debbie, and also thank you, Casey, for arranging this webinar and allowing me to present this topic, which is very near and dear to me. Good afternoon and welcome everyone, all my participants for joining this webinar. It is wonderful to see so many participants from the community members ready to hear about the strokes. I'm really excited. As you mentioned, Debbie, that yes, there is always when we have or we heard this, the disease called stroke, we really get panicked and we are very nervous if one of our loved one is going through a stroke symptoms. So I hope that with this presentation, I will be able to focus few of these strokes symptoms and what should we do when we see someone is having a stroke, and I hope it will benefit our community members. So let's get started. So what should you do when you see first that someone is having a stroke? The first thing you need to do is stay focused, stay calm, and take action. What is that action? You can call 911 immediately. And the most important things, what we would like to know from the bystanders or from the witness is the time of onset. When the symptoms started, that is the most important piece of information. You can help us by knowing it. So that is the second thing you should pay attention when the symptoms started. And the next thing is you can perform CPR if necessary. So I'd like to just highlight few points on the CPR, particularly during this COVID time. For those who are not familiar with the CPR, it is a cardiopulmonary resuscitation where there are two main components. One is the breathing component and like breathing through mouth to mouth, and the other component is the chest compression. So I know that now we are going through this pandemic, COVID pandemic, and there is a concern that whether is it okay to give this mouth-to-mouth breathing or touch someone or feel someone's pulse when they are possible suspect COVID case or something. So the American Red Cross and the American Heart Association came out with a recommendation for about the victims of sudden cardiac arrest to receive continuous, it's called the compression only CPR if you are not comfortable breathing in suspicious COVID cases. It saves lives compared to no CPR. So the compression with the breath is the most effective CPR in the case of children and infants and the people those whose heart have stopped due to the drug overdose. But for the other people, the compression is enough to, at least at this time and moment, that was the recommendation that the compression would be better than the no CPR. Having said that, one thing we also need to just keep in our mind that the data shows that 70% of the out-of-hospital cardiac arrest happens at home, which means you are already exposed to the patient being a family member or being the same household member. So you can consider mouth-to-mouth breathing, but in case the patient is in isolation or you have not exposed, then it is reasonable to skip the breathing part and do the chest compression with the appropriate PPE. Next slide, please. So let's talk a little bit about the stroke statistics. You can see in the slide that there is every 40 seconds, a stroke happens in the United States. Think about that. By the time we finish our talk today, there will be 90 people affected with the stroke. That is why it is considered a medical emergency. We need to treat it immediately within 3 hours, but in some cases, we can treat it until 4.5 hours. And I will discuss more as we proceed. Next slide. Few more facts about our brain, which is a fascinating organ. When someone has a stroke, 2 million brain cells die every minute, though we have a total of 100 billion billion cells in our brain. But without prompt treatment, a part of the brain the size of a pea dies every 12 minutes. Now, I think we can understand the need for emergent treatment in stroke patients if you keep that information in your mind. So we can say that the time lost is brain lost. So the time is the essence of managing stroke. Next slide, please. Let's play this video to spot a stroke, how we spot a stroke.
Quiet, please. Wait a sec. I'll take one. Oh yeah. All right. All good. Take care. Way to go. Nice. Bring it on. Gotcha. I'm here for you. Oh no. Please, please, please. I'm waiting. Interesting. Not buying it. Not fair. That's it. This conversation is over. Oh, brother.
Body language can tell you all sorts of things.
Having a stroke. I'm having a stroke.
Know the sudden signs. Learn fast. F. Face drooping. A. Arm weakness. S. Speech difficulty. T. Time to call 911 immediately. The sooner they get to the hospital, the sooner they'll get treatment. And that can make a remarkable signs in their recovery. Learn the body language, the sudden signs, and spot a stroke fast.
Excellent. So that video talks about the fast sign, but recently the American Stroke Association added 2 additional signs to detect the stroke. As you saw on the video, that the fast is FAST, F for the face, A for the arm, S for the speech, and the T for the time. But the 2 new additional information we are looking for is called the B and E. So the B for the balance and E stands for the eye problem. So the balance problem, it could be a sudden dizziness or trouble walking, or in case of eye, the sudden trouble seeing out of one or both eyes. So if you have any of these, if anyone has any of these symptoms, then you could at least start thinking of stroke and start acting on that symptoms. One point I just want to emphasize here is the mode at the onset. Stroke symptoms happen all of a sudden. So it hits you out of blue. And this is why the timing of symptom onset is so important to us. As I mentioned earlier, current guidelines recommend using the blood thinner in ischemic stroke patients within 3 to 4.5 hours of the time onset. However, the study showed the sooner you treat the stroke, the better the outcome, preferably within 90 minutes of onset. So that is why, again and again, we emphasize on this onset. The time of onset is very, very important for us to know. Next slide. Okay, so we learned a little bit about the facts and about these statistics about the stroke. Now let's see exactly what is a stroke. So a stroke occurs when a blood clot blocks a blood vessel and when a blood vessels rupture, interrupting the blood flow to the brain. And when this happens, the brain cannot get the blood and oxygen it needs, so that it dies along with the brain cells. I just want to imagine your plumbing system of your house. Just think about it. So when you turn on your kitchen faucet, the water starts running, right? But say one day you went to the kitchen and turned on your faucet, but there was no water coming. So what could be the problem? What do you think? So it could be you do not have water in the main water tank. This could be the one problem. What the other problem? Or it could be the pipe that is clogged because of the iron buildup inside the pipe. That's exactly what happens when there is a stroke. Just imagine the brain is your kitchen faucet. The heart is the water tank that contains the blood. With each heartbeat, the blood expelled out from the heart and circulates all over the body. So the blood volume and pressure is your water pressure, and the blood clot is your clogged pipe due to cholesterol plaque built up within the blood vessels. So when a stroke patient comes to us, we try to figure out where the problem is. We will discuss this concept again when we talk about the types of the stroke later. Next slide. So now we can see how the brain and the heart are so interconnected and dependent on each other. Remember, we just explained that the heart pumps the blood circulates and goes to the brain. So these are the few or 3 terms I want you to understand and not to make confusion. One is the heart attack, and one is the cardiac arrest, and one is the stroke. So the heart attack is when the blood supply to the heart is severely reduced or cut off. So there's lack of oxygen to the heart muscle, and it will die. With the same concept, the stroke happens as well. So when there is a stroke happens means there is an interruption of the blood supply to the brain. It does not get enough nutrients and oxygen, and the brain tissue starts dying. So you can say the stroke means a brain attack. So it's a heart attack means the heart problem, and the brain attacks means the brain problem. In contrast, the cardiac arrest is an electrical activities that heart suddenly stops beating and preventing blood and oxygen from getting to the vital organs. So in both cases of the heart attack and the stroke, the blood flow is severely reduced or cut off, and consequently the cells start dying. On the other hand, in the case of a cardiac arrest, the main issue is abnormal electrical activities and the heart stops beating, and we need to do CPR. In my experience, I see many times when I ask a patient whether he or his or her relatives has any past history of past stroke, and they replied yes, the person may had a stroke 2 or 3 years ago, and they put a stent on his heart. So I understood that maybe it's not clear to them that the putting a stent in the heart does not mean that it is a stroke. It's actually a heart attack, not a brain attack. Hope it will clear the difference between the heart attack and the brain attack and the cardiac arrest. Next slide. Now let's talk some stroke facts. Few are related to general population, but others are gender specific. You can see on the slide that stroke is the fifth cause of death and a leading cause of disability in the United States. So back in my training time when I started the residency, the stroke was the fourth cause of the leading cause of death in the United States. So we are proud that we could make progress on that. We could make it now, bring it down to number 5. In 2018, 1 in every 6 deaths from cardiovascular disease was due to a stroke. Someone in the United States has a stroke every 40 seconds, as we mentioned earlier, and every 4 minutes, someone dies of stroke. 80% of the strokes are preventable. And the facts related to women is that the stroke kills twice as many women as the breast cancer does, and making the stroke third leading cause of death for women. So just keep that in mind, that it is the 5th leading cause of death in a general population, but the 3rd leading cause of women in case of women. And the facts related to men, the stroke kills almost the same number of men each year as prostate cancer and Alzheimer's dementia disease combined. So you can understand how many strokes actually happen in case of male. Next. Okay, so we learned that what is stroke, how it happens, the statistics, the facts. But what is your risk? What should you do to prevent a stroke? We need to understand this right now. Next slide. So this is, you can see the risk factors. Some are related to the lifestyle change, and some are the medical risk factors. So the potential treatable stroke risk factors include the lifestyle change, being overweight or obese, physical inactivity, heavy or binge drinking, and any kind of illegal drug use like cocaine and methamphetamine use. On the other hand, if you have some underlying medical risk factors like the high blood pressure, cigarette smoking, high cholesterol, diabetes, obstructive sleep apnea, and any cardiovascular disease, including the heart failure, heart defect, heart infection, or abnormal heart rhythm, such as an atrial fibrillation. And if you remember, we just talked about how the heart and the brain are so interconnected. So any disease in the heart may be an outcome. A stroke could be an outcome for that from that heart disease. And also some cases, not all strokes, there is definitely a genetic component or like a personal or family history of stroke. The COVID-19 infection can play a role as well. We're going to talk a little bit more about that in next slide. But just keep that in mind that these are the risk factor for the stroke. So in that sense, you can understand actually the most of the strokes actually happen because of something else in your system, because you have long history of high blood pressure, because you have long history of cholesterol, high cholesterol, because you are diabetic, or because you have atrial fibrillation. So the stroke for any of these causes, if the stroke happens, you can understand or you can think the stroke sounds like a victim for all these underlying risk factors. So the better you can control these risk factors, we expect that the chance of having the stroke in your case will go down eventually. Next slide. So, and as like the other stroke factors, some are we cannot change, we cannot modify. What we call is a non-modifiable risk factors, like age. I cannot do anything about age. We all hope we could stay younger, but that's not the case, unfortunately. So the people age 55 or older have a higher risk of stroke than do younger people. The African Americans are at higher risk. The men have a higher risk of stroke than women. The women are usually after the menopause, their stroke risk start going higher and higher because of some hormonal contribution. And also the young females who are on the birth control pill, or the elderly female, those who are on hormonal therapy, replacement therapy, that include the estrogen, increase your risk for stroke. Next slide. So now we're going to talk a little bit about the types of the strokes. And again, going back to the same concept as I was explaining to you, the plumbing system of your house. So we talked about that the one day you go to your kitchen and found that you turn on the faucet, but water was not coming. And we said that some possible explanation that it could be your main water tank does not have enough water, or you do not have your enough water pressure, or it could be a clogged pipe that is not that's blocking the water to coming to your sink. So that is in one scenario. The other scenario, it could be like you can go to the kitchen and you find that the water spilled all over the floor. So when you turn on the faucet again, there was no water. But this time, the problem was not in the water tank, not in the clogged pipe, not in the water pressure, but this because the pipe was burst. So this is called a hemorrhagic stroke or bleeding type of stroke. And the other one, what we described earlier, the clogging system, is called the ischemic stroke. And you can see on the screen that the most of our strokes in this country, the 85% of the strokes are what we call a clotting type stroke or ischemic stroke. And the 15% are called the hemorrhagic stroke or the bleeding type of strokes. Next slide. And this is what we just explained here. This the ischemic stroke happens when the brain blood vessels become narrowed or blocked and causing severely reduced blood flow. That is called the ischemia. And some initial research right nowadays shows that the COVID-19 infection may be a possible cause of ischemic stroke, but more study is needed. We are collecting the data all over the world right now, actually collecting the data. There's COVID-19 and the stroke, what is the relationship and what is the mechanism is that? So we are working on that. But so far, whatever data we have collected, it shows that all these strokes related to COVID-19 was an ischemic type, not the hemorrhagic type. Next slide. So you can see on this slide that the hemorrhagic stroke occurs when a blood vessel in your brain leaks or ruptures. And like as I mentioned, that there are some risk factors for the ischemic stroke, like your blood pressure, high cholesterol, diabetes, atrial fibrillation, any heart disease, smoking. But what about the risk factor for the hemorrhagic stroke? the most important risk factors for the hemorrhagic stroke is the uncontrolled high blood pressure. So you can see that the blood pressure plays a very important role in stroke. Either it's an ischemic stroke or it's an hemorrhagic stroke. Both strokes can happen because of uncontrolled high blood pressure. This one thing, generally speaking, again, keep that in mind, that the high blood pressure damage your brain more than the heart, and the diabetes damage your heart more than the brain. But both the blood pressure and the diabetes can affect actually both brain and the heart. But one is affecting more than the other organ. Again, high blood pressure mainly affects the stroke, cause the stroke, and the diabetes mainly affects the kidney and the heart. The other causes or the risk factors for the hemorrhagic strokes could be using blood thinners. And definitely you need to use blood thinner for many reasons. It could be an atrial fibrillation. It could be having a previous stroke. It could be because of your cardiovascular risk. So being on the blood thinner increase your risk of hemorrhagic stroke. The other risk factor that is another most common in the hemorrhagic stroke world is called the aneurysm, or the bulging out or weak spot in your blood vessels. And the last thing is the trauma. So the trauma, aneurysm, and blood thinner, using blood thinner, and uncontrolled blood pressure. These are the main risk factors for the hemorrhagic strokes. Next slide. Let's talk a little bit about the atrial fibrillation, because again, almost one third of our ischemic strokes are due to atrial fibrillation. And going back to the same idea or same concept, that in this case, the brain is the victim of the heart problem. So we need to fix the heart problem to prevent the further stroke. But what happened in the atrial fibrillation and why it is so important to know, and what is the mechanism of the atrial fibrillation causing the stroke? So the atrial fibrillation, or in short, we call is an AFib. So the atrial fibrillation is an irregular rhythm in your heart. So you can see on the screen the normal ECG or the EKG, it shows kind of a rhythmic wave. In contrast to that, in the atrial fibrillation patient, their heart look like a chaotic. There's a chaos going on in the electrical activities. So what happened is that because of the abnormal rhythm, the heart, instead of pumping out the blood, it's actually like kind of a quavering, is beating too fast. So what happens if it beats too fast? So because it beats too fast, that it does not actually squeeze. So if it does not squeeze, then the blood does not expel out, rather it stays within the heart. And if it stays within the heart, then it causes a potential risk for the blood clot formation. And the next time when heart squeezed, that blood clot expelled out from the heart and goes to the brain and cause the stroke. So you can think about the waterfall or the running water. If you notice the river water or the waterfall, the water that is constantly running, we consider these water as clean water. But if you want to keep water in a jar in anywhere, after 2 days or after 3 days, you can see that there are germs start forming and different particles start forming in that stagnant water. So any water that is stagnant is a risk for formation of germs. In contrast, the running water has less chance to form any germ. The same idea or same concept in case of atrial fibrillation. If the blood stays within your heart, it's a stagnant blood, and the stagnant blood is a high risk for forming blood clot. And if the blood is in the circular motion, then there is a less chance for blood clot formation. So that's how the atrial fibrillation is playing a role in stroke. And that is why it is so important to identify the atrial fibrillation because the treatment is completely different in case of atrial fibrillation. Next slide. And you can see these facts about the atrial fibrillation here. Approximately 5 million people in the US have atrial fibrillation. It is 5 times more likely to suffer a stroke when patient has atrial fibrillation. 15 to 20% of all strokes are AFib related. As I mentioned, like almost our 1/3, kind of 20% to 30% of our cases are AFib related. It is really, really important to identify the patient for the atrial fibrillation. The next slide. What are the common symptoms of the atrial fibrillation? How do you know that you can have what you are looking for? Unfortunately, there are bulk of the patient, they remain asymptomatic, meaning you do not know or you do not get any symptoms. So that is the reason it is so hard for us sometimes to detect the atrial fibrillation. But when you feel the symptoms, these are the things you can pay attention or you look for. Once the racing of your heart, what you call the palpitation or fluttering, shortness of breath, lightheadedness, or maybe noticeable symptoms, as I mentioned earlier. So if you experience any of these, and again, the shortness of breath, there are many reasons of shortness of breath. There are many reasons for the lightheadedness. So having experienced any symptoms of shortness of breath, we don't need to conclude that it is an atrial fibrillation. You need to talk to your doctor to do more work to figure that out. Next slide. Okay, now I think you already have a very good idea about the stroke, how it happens and what happens. So let's talk a little bit of the misconceptions. What are the myths and what are the facts? So in the community, the myth is the stroke is not preventable. The fact is, yes, as we mentioned, that about 80% of the strokes are preventable. And if you remember, I said that the main risk factor for the strokes are the high blood pressure, cholesterol, diabetes, smoking, using drugs. So if you can control these, you can prevent further stroke almost 80%. Stroke cannot be treated. We're going to talk a little bit later about the treatment, but as we mentioned that it requires an emergency treatment. Another myth is the stroke only strikes the elderly. Again, if you look back, what we talked about, that the stroke can happen anyone, those who have any of these risk factors. So if a younger patient uses drugs, then their stroke risk is very high. If they smoke, their risk is very high. So it's not an age specific, but yes, we mentioned that the elderly patients are at higher risk, but it can happen at any age. And the other myth is the stroke happens in the heart. I'm pretty sure by this time you got pretty clear idea that no, when it happens in the heart, we call it a heart attack. But when the same mechanism happen in the brain, we call it a stroke or the brain attack. Another myth is the stroke recovery ends after 6 months. And that's also not true. The fact is the stroke recovery continues at least 2 years. And again, it could be a lifetime, but at least, not at least the 6 months, at least we can say 2 years. Next slide. Now talk about the treatment. So there are two approach. One is the medical approach or the medical management, and one is the procedural management. So the medical management is and this is what we are talking about, the particular type of stroke that is more common in the community, is the ischemic type or the blood clotting type of the stroke. You remember we said that 85% of our strokes happen because of the blood clot. So we use a medicine called a clot buster medicine. And that medicine been approved by FDA in 1996. And that was a game-changing medicine for a stroke world, actually. Believe it or not, before 1996, if you were to go an emergency room with a UTI, urinary tract infection, and the other patient comes to the stroke with the stroke symptoms, UTI patients were to see earlier or before the stroke patient was seen, because there was no medicine, there was no treatment for those patients, immediate treatment. So in 1996, when the FDA approved that the medicine is called the clot buster medicine, the most commonly known as in the community is a TPA. When you go to the emergency room with a stroke patient with your loved one, you will first, when you see a physician, they will try to figure that out, that whether this particular patient would be a candidate for TPA or not. So you will hear this term TPA. It's called tissue plasminogen activator. The common name, as I said, the clot buster. So that is the approved medicine. But the problem with this medicine is we have to use that medicine within 4.5 hours of that symptom onset. And again, going back to that piece of information we want to know from you, that when the symptoms first started. If it started within last 4.5 hours, you will be qualified for that medicine, having some other criteria to meet the other criteria. But if you are more than 4 and 5 hours window, then unfortunately we cannot use that medicine because it causes more damage than the benefit. But preferably, we want to treat even within 90 minutes, not 4.5 hours. 4.5 hours is the extreme window. Then after that, we cannot use it. So what is the other approach? The other, if we cannot use that medicine, if you come to me at 6 hours and I cannot use that medicine, does that mean that is the end of the story? No. So in 2015, after 19 years after this medicine been approved, another game-changing trial came, and this is called the thrombectomy or the procedure. So this is a endovascular procedure to remove the blood clot by sending a catheter, is a flexible tube, to the site of the blocked blood vessels in the brain. But again, the patient must meet certain criteria to be eligible. It is not a one-size-fits-all approach. So this is limited for limited patient, but again, this is at least a window for right now. We can treat up to 24 hours. So imagine we started with only 3 hours, then we extended it to 4.5 hours for the medicine. And right now with the procedure, we can even extend the window up to 24 hours, okay? Does not mean that you should stay up to 24 hours to come to the hospitals. Again and again, we are emphasizing, sooner you bring the patient to the hospital, better the outcome. Next slide. And this is kind of a breakdown that when you call the 911 and bring the patient to us, remember one thing, and we are very proud of as a stroke committee, as a stroke team, we are very proud of that every steps is counted and monitored, okay? So you can see this is the protocol from the American Stroke Association, and to get the accreditation, any hospital, we have to meet that criteria or goal. So the moment the patient hits the ER door, within 10 minutes, we have to evaluate the patient. We get to start the lab work. We call the stroke team. Within 15 minutes, the stroke team needs to see the patient. Next slide. Within 25 minutes, we get the CT scan. Within 45 minutes, we get the CT scan is read. And within 60 minutes, we actually infuse that medicine, the TPA or this clot buster medicine. And again, we are also proud of that we actually, most of the hospitals achieve that goal of door to needle time, what we call it, means when the patient hit the door and when we use the medicine, this is called the door to needle time. Needle means you are using that medicine. It's 60 minutes. Now we are bringing it down to actually 45 minutes. Okay, so the goal is door to needle time to 45 minutes. And in few cases, we also bring it down to actually 30 minutes. So keep that in mind. That's why the time is so important, and you should not waste your time to know what's going on, because every minute you waste, we're gonna miss the window opportunity for treating those patients. Next slide. These are the statistics in the study shows that with that medicine, when you dissolve the blood clot, 30%, 13%, 13% of the patients get completely normal. Another 19% got better. 62% remained stable. At least they did not get worse. And the risk of this medicine, every medicine has its own risk factor. The risk of this medicine is it can cause a brain bleed, and the risk is 6%. So what does that mean is if I give that medicine to 100 stroke patients, 94 of them will not bleed. Only 6 of them can end up bleeding, but this is the only approved medicine. And with the procedure right now, this thrombectomy, half of our patients actually improved compared to those who did not get the procedure. Next slide. So when the patient got admitted, we did the treatment, and when the discharge time comes, is that the end of the treatment for the stroke? No. To be honestly, that is actually the beginning of the treatment starts. So we take care of the stroke patients in the stroke in an acute emergency settings to make sure their blood pressure is well controlled, their blood sugar, their diabetes, the blood cholesterol remains stable. And then when we do all the workup to figure that out, what caused the stroke, that take about 48 hours to complete all the workup. And then depends on the stroke severity and symptoms, we start talking the next step. And what is the next step? Next step is the rehabilitation. And that is the very, very important part of the stroke treatment. So this, after we discharge the patient, then they depends on their severity of the symptoms. They can go to the inpatient rehab, they can go to the outpatient rehab, they can go to the nursing home. All depends on their symptoms severity wise. But the rehabilitation is the mainstay of treatment after the acute care is taken care of. Next slide. So now we're going to talk a little bit about the COVID-19. And as you, by this time, I believe that you have understood very well that how important it is to come to the hospital in a timely manner, in a timely fashion, with a patient who you suspect having a stroke. So you can see that past few months, almost 25 to 50% decline in ER admission due to stroke. And the reason was basically the fear of contracting the COVID-19 at healthcare facilities. And I do not blame anyone. This is very normal. This is very natural instinct, like going to the hospital in the COVID pandemic time. But again, just to understand that as a physician community and as an expertise, we always will make you aware that if you do not need to come, like if you understand that when the COVID hits first time in the beginning of the March and April, almost the nationwide, we stopped all kinds of elective surgeries, right? But we never stopped the acute care of the stroke, acute heart attack, care for the heart attack and all these things. These things should never be stopped. So if you do not get any such kind of information from your expertise, from your physicians, please do not delay to bring your patient to the hospitals. Right. Again, if you remember, we said this time window is very, very important. And we are well equipped. Most of our stroke centers are well equipped to handle the situations, to minimize the contamination from the COVID, and to give the treatment for the stroke. Next slide. So again, stroke don't stop for a pandemic. Nearly 1/3 of Americans have put off healthcare during the COVID. That is the reason we want to our community people to aware them that we should not stop bringing these patients to the hospital to get the care. Next slide. So you can see here some examples of delayed care we have seen at our Baylor Scott & White healthcare facilities because of the pandemic. So unscheduled breast cancer surgeries, untreated abdominal conditions, pronounced congestive heart failure, significant pulmonary conditions, and advanced infections. All these are acute conditions that we should not delay to bring the patient get to the medical attention. Next slide, please. So this is what we talked about. This our the safe care. That is, as I said, that we should not delay. We are well equipped to give the treatment with the minimizing the transmission of the COVID. Next slide. We can play a video to just to give you an idea how we are taking care of the patients during the COVID time.
At Baylor Scott and White Health, there's nothing more important to us than your well-being. Over the last several weeks, we've done a number of modifications to our emergency rooms so you can continue to get the care you need when you need it. We're regularly cleaning and disinfecting frequently touched surfaces in our lobbies and patient areas. When you arrive, a screener will check your temperature, and we're requiring everyone to wear masks. When it comes to registration, we've got a no-touch process. You'll just answer a few simple questions. We'll get you back to our room as quickly as possible. We want you to be well informed and not ignore symptoms that could indicate a potentially serious condition. In those situations, it's critical you don't delay. To learn more about all we're doing to help keep you safe, visit bswhealth.com/safecare.
Okay, so again, from Baylor Scott and White Health Emergency, as a healthcare provider, we are working tirelessly to provide care for those who need it, including people who are showing signs of stroke. And our facilities are taking steps to keep all patients safe and help prevent the spread of COVID-19. We want patients to have confidence that their safety is our top priority and to feel peace of mind when scheduling and receiving care. That's why we announced our COVID-19 Safe Care Plan back in May. The plan is a combination of new preventive measures and digital offerings to keep our patients, visitors, and employees safe, as we just shown in the video. We know some of you have put your health on hold over the past several months. That is why we are committed to educating our communities about the many ways we are working to safeguard their health and well-being, as well as that of our caregivers from COVID-19. It's important you do not delay any longer. Thank you so much. And now I'm gonna go ahead and take some questions. Please feel free to ask if you have any questions. I'll be happy to answer.
So Dr. Hasan, first I want to say that was such an interesting presentation. I actually learned something that I didn't know. I did not know that strokes happen in the brain. I always thought that they were in the heart. So the slide that you talked about the differences between heart attack, cardiac arrest, and stroke, I found that to be very interesting. So again, thank you for that informative presentation. And yes, this is our time for questions. Let me see what we have here.
Thank you, Debbie.
You're so welcome. So I see one of the questions is whether or not you'll cover ischemic stroke, and I know that you did. So let's move on to the next question. Can stroke patients fully recover?
Yes, majority of our stroke patients recover. Again, as I said, that most of the patients, if it is a mild stroke, it depends on the severity of the stroke, the location of the strokes. Remember one thing, that the brain controls the whole body. So it controls our arm and leg movement. It also controls our speech. It also controls our breathing, blood pressure, and everything. So, but not the whole brain controls everything. So part of the brain controls our movement, part of the brain controls our speech. So it depends on where the stroke is. The recovery also depends accordingly. But generally speaking, almost 80% of our stroke patients, they recover very well.
Thank you. What foods should you eat to prevent a stroke?
Very good question. So in terms of the food, actually, again, if you remember during the presentations, we talk about the heart and the brain. We always emphasize on these things. The heart and brain are so closely related. So whatever you think heart healthy diet is the good food for the stroke, to prevent the stroke. From the American Stroke Association, we recommend, this is called the Mediterranean diet. If you go to the American Stroke Association and you type on the search link, you will find it. The Mediterranean diet is basically all the heart healthy foods, like eating most of the time green leafy vegetables, fish, chicken, avoid fried food, avoid meat and beef, and the pork, and eating mainly the heart healthy diets, avoiding the carb, sugar. These are the main, and this is again called the Mediterranean diet. If you type it, you will find it there.
So this is a good question. What is the optimum blood pressure range?
The optimum blood pressure range, it depends on your overall health conditions. Just to keep that in mind, that when you first get to the hospitals, we try to keep your blood pressure higher than normal. So sometimes patient gets surprised that I came to the hospitals, I came on time, and the doctors are keeping my blood pressure higher than the normal. And that's what we want right after the stroke, means first 24 hours, we want our blood pressure to be a little high, because if you remember, I talked about the mechanism and I said that the blood and the water pressure to go up to the brain, and that's why we want the blood pressure to keep a little higher. But as time goes by, means like after 48 hours and 72 hours, we gradually bring it down. If you do not have diabetes, underlying diabetes, your blood pressure goal is below 140/90. Again, if you do not have diabetes, your blood pressure goal should be below 140/90. The upper number 140, lower number 90. If you have diabetes as well, in addition to the stroke, we want your blood pressure a little tighter control. And in that case, your blood pressure goal is 130/80. So again, the 130 is the top number and 80 is the bottom number. If you have stroke and diabetes. If you have only stroke, the blood pressure goal is below 140/90, 140/90.
Okay, Dr. Hassan, what do you do if you live alone and you have a stroke? There's no one there to help you.
Unfortunately, if you can call at least 911 the moment you feel any of those stroke symptoms, as we explained, like the face, arm, leg, speech, or eye problem, you should call 911. If you cannot call 911, or if you can call someone, your relatives, then that would be the thing you should do. And if you are at higher risk of stroke patients, then you should have a arrangement like a life-saving button, or that kind of arrangement ahead of time, that if anything happened and if you get a chance, you could at least press that button.
Can aspirin reduce one's chances of getting a stroke?
Absolutely. Those are very good questions. And just keep that in mind, that if you suspect a stroke, do not take aspirin until you get to the hospitals. It is the opposite for the heart attack patients, or if you suspect a heart attack patients, because for the stroke patients, as we say, that there are almost 15% risk, 15% of our stroke is the hemorrhagic or the bleeding type of strokes. With aspirin, it may get worse. And there is no way to confirm whether this is an ischemic, the blood clotting type of stroke, or hemorrhagic type of stroke without doing a CT scan of the brain. Being a stroke specialist, based on the symptoms, we can kind of pretty accurately guess it. We can guess that this is an ischemic type or the hemorrhagic type, but we could not be certain. So to confirm, we need to do a CT scan of the brain. And once we do the CT scan, then if it is not a bleeding type of stroke, then we give them the aspirin. So for your understanding, if you suspect that you could have a heart attack, you or your loved one, then surely you can give the aspirin. But if you think that it could be a sign of a stroke, then do not give any treatment, do not give any aspirin. Rather, you call 911 and bring the patient to the hospital. We do a CT scan first. then we will decide what to do. But after that stroke is taken care of, then for the long-term management, you should take aspirin for sure.
This is an interesting question. So, if you have uncontrolled blood pressure, should you assume that at some point in your lifetime you will have a stroke?
That is very highly likely, but in medicine, nothing is 100%. So we cannot say for sure or for certain that you will have. To be honestly, there are lots of people walking on the street with 180 systolic blood pressure, and they never had any stroke. On the other hand, the people, those who are 150 blood pressure or 160 blood pressure, they can have a stroke. But generally speaking, yes, if you have a high blood pressure, you are at higher risk of stroke, either type of stroke. Remember, we talked the blood pressure actually increase the risk of both high blood, the ischemic type and the hemorrhagic type. So yes, in generally, your risk is very high.
Okay. And someone just wanted to say thank you, Dr. Hasan, because you're doing such an amazing job.
Oh, thank you so much.
So our next question is, having 3 or more TIAs, does this put you at risk for a massive stroke?
Yes. If you have a TIA, if you even have a 1 TIA, you are at higher risk of stroke. Let me just clarify what is the TIA is here. The TIA stands for the transient ischemic attack. So it is a stroke-like symptoms that happens, but it is, if you understand, it is a transient, means the symptoms usually resolve on its own within 24 hours by definition. But in our experience, we actually find that the symptoms usually resolve within even 20 minutes to 2 hours, kind of that range. So if you have a stroke-like symptoms, means the symptoms what we described earlier, the face, arm, speech, or the eye problem or the balance problem, then yes, it could be a TIA. And that means it is a warning sign for you to be careful that it is kind of a, the storm is coming. So be careful about that. You talk to your doctor, get all the tests done. We do exact same workup and investigation for a TIA patient that we do for our stroke patients. So yes, if you have a TIA, then you are at higher risk for a stroke.
Can you have more than one stroke? And if you do they get worse with each one?
Yes, they get worse. But again, if you remember, we talked about that the stroke depends on the location of the brain where it affects this, the stroke. So if you have in the same location, like very close by the area, then your risk definitely, your symptoms will get worse. But if it is in a different location, like one time on the right side and the other time on the left side, then we usually try to understand and figure out why you are having too many strokes back to back, and how to prevent and how to protect having another stroke. But by itself, definitely it can cause worsening of your disability, worsening of your outcome.
So the next question is about exercise, which I honestly am very interested in right now with COVID and we can't get to the gym. Is there a particular kind of exercise to prevent stroke?
Absolutely, a good question. Again, this yes, the exercise is the recommendation from the stroke standpoint is what we call an aerobic exercise. You can do every 30 minutes, every day 15 minutes, or every other day 30 minutes. That is the recommendation. What do we mean by aerobic exercise? The aerobic exercise means like any running, brisk walking, swimming, biking, treadmill, like the exercise that is not a 100-meter sprint. That is an anaerobic exercise. Aerobic exercise means like with your pace, eventually you increase the exercise intensity over time. Like as I said, that biking, running, jogging, swimming, treadmill. So you can do every day. If you can do every day, the 15 minutes is enough. And at an extent that it breaks sweats, If you cannot do every day because of your work schedule and everything, you can do every other day. In that case, recommendation is to do 30 minutes of exercise.
One of our participants takes Plavix daily and wants to know, are there any additional risk factors for a massive stroke? I'm thinking because of taking Plavix.
Yeah, so because of taking Plavix, we need to know why are you taking Plavix. But if you are needed to take Plavix, whatever the reason, it also prevents your stroke. It could be an aspirin or it could be a Plavix. Either way, you are protected from the stroke. But having said that, remember the Plavix itself is a blood thinner. So any blood thinner can increase your potential risk for bleeding type of stroke. I am not saying you that you should stop it. Do not take is in this way this message that okay, I am in Plavix, so my stroke risk is high, bleeding type of stroke, so that I should stop it. No, any medicine has its own side effect and benefit. So when we decide to prescribe any medicine, we want to see is your benefit outweigh the risk or the risk outweigh the benefit, and that's how we decided. Having been on Plavix, definitely it protects you also one type of stroke, the ischemic type of strokes. You may be on Plavix because of your heart condition, because of any other condition, or even because of the stroke, previous stroke. And you should continue, you should not stop Plavix. It will prevent your stroke, one type of stroke. And the other type of stroke, as I said, that it is not only because you are on the blood thinner, but if your blood pressure remains very high when you are on blood thinner, or if you add one more blood thinner on that, then your risk of bleeding type of stroke can go high.
Okay. Is there pain associated with having a stroke?
No pain associated with a stroke. That is only the good thing about the stroke. And I do not say good thing. Definitely having stroke is not a good thing. But yes, we are very much concerned about our loved one when they go through the stroke, whether they are suffering. The only the hemorrhagic type of stroke, that is, again, remember that the bleeding type of stroke, that is only 15% of our all stroke type. It can cause headache. It can cause nausea and vomiting because of the increased pressure in the brain, but it does not cause any bodily pain. And the ischemic stroke, 85%, they do not cause bodily pain at all. So the stroke patients can suffer in a different way, but not because of the pain.
Okay. If someone has a TIA, should this last beyond a year? And if so, does it affect one side with weakness?
Again, remember we said the TIA definition is your symptoms needs to be resolved within 24 hours. If your symptoms persist more than 24 hours, that means it was not a TIA. It's something, I do not know what it is. It could be a stroke, it could be something else, but not TIA. By definition, TIA should be resolved, the symptoms should resolve within 24 hours. So if your symptoms persisted, then I think you may need to go and see your doctor and see what exactly happened, that why you are still having the symptoms. So after 1 year, absolutely, you should not have similar symptoms again.
So we talked about exercise a little earlier. One of
Sure.
our participants says that she was able to come off of high blood pressure medication as a result of exercising regularly. I'm not certain of the question, but it says, can the doctor address exercise? Maybe perhaps she's saying what
Yeah,
types of
I think,
exercise?
again, if you come off the blood pressure medication, I believe that definitely your physician, if your physician made the decisions, then I believe that he or she feels comfortable to do that. In that case, you actually lower or cut down one of your risk factors. So remember, these strokes, the risk factors of the stroke is high blood pressure, cholesterol, diabetes, smoking, age, and all these things. So if you can cut down, that's a good sign. Then you should continue doing exercise, continue taking the healthy diet. And that's, if you have other risk factors like diabetes or high cholesterol, then you should take care of those things. But yes, you can continue doing exercise, what we explained earlier. Again, what we call an aerobic exercise, like walking, jogging, biking, swimming, Yeah, this type of things.
Are there reasons for why there could be a drop in your blood pressure, say around 100/50?
100/50, you said?
Yes.
Okay. Yeah, there are many reasons of the blood pressure drop. It could be if you are on medication. That's the one thing you can remember. The blood pressure is always a dynamic thing. Okay. Um, that means that it is not a static number. So sometimes your blood pressure can drop to 100/50. Definitely, that's what we do not want. We want your minimum blood pressure at least 110 to 120, and the lower number is 60 and above. But if it happens, then recheck your blood pressure. It could be dehydration is the most common cause of the low blood pressure. If you are not very sick, means do not have any fever or do not have any chill, you are not confused, only blood pressure drop, it could be an isolated event. Check, make sure that you are drinking enough water and keep yourself hydrated. And is there any medication change recently of your blood pressure medication? If not, then recheck your blood pressure after 30 minutes. That would actually, you can see maybe the blood pressure also change. Or sometimes it remains low, but you don't need to be panicked because every human body is a kind of knows its own base numbers. Okay, for me, normal blood pressure may be 120 for myself, but my brother, his blood pressure may be 140 is the baseline. So it does not mean that my blood pressure needs to be 140 or does not mean his blood pressure needs to be 120. If your blood pressure always remains 110 or 100, that might be normal for you. You may not need any treatment, but you have to make sure that this is what your normal blood pressure. But if it runs always 140s and suddenly drop to 100, then yes, you may need to get an attention to talk to your doctor. But normal common cause is the dehydration.
Okay. Now, does stroke cause gastroparesis, weak bladder, or blurred vision?
It can cause blurred vision, but usually it does not cause gastroparesis. And if it does, it's actually a transient. Again, going back to the same concept and idea, if you remember, I kept saying it, that the brain controls our everything. So the gastroparesis is also controlled by the stroke. By the brain. So if your stroke happened in that particular area, it might cause some problem. It actually affects your swallowing rather than the gastroparesis. So the swallowing is the most important thing that can affected by the stroke. But the gastroparesis is less likely. Even if it happens, it is a temporary. It will improve over time. But the blurred vision, yes, it's common with the stroke.
How much do OVC anti-inflammatories contribute to plaque or other blood vessel issues?
How much? I'm sorry, what is O?
How much do OVC anti-inflammatories contribute to plaque or other blood vessel issues?
So the anti-inflammatory is always good to prevent the stroke. And that is why the Plavix also has some anti-inflammatory effect. And the aspirin also has very minor anti-inflammatory effect. So when there is a cholesterol plaque, when the cholesterol start building up in your blood, there is a cascade of event going on one after another. It's kind of a domino effect. And one of the effect is because of this inflammatory effect. So that's why if we use anti-inflammatory, that plays a role to prevent the formation or further progression of the clot formation, the plaque formation there, cholesterol plaque. So yes, that it has an important role to prevent the stroke by preventing the formation of the cholesterol plaque.
Dr. Hasan, you answered a lot of questions. I think we had a total of 16.
Oh, good. I am very glad that, definitely this is a sign that our community members and our community people, they are eager to know about the stroke, and I'm very glad. And I'll be very happy to what I can do for them in future to to just spread the message, to give them some education to help them to know the risk factors of the strokes and how to prevent it.
We have about 9 more minutes for Q&A. We do have one more that just came in.
Sure.
Is sudden or drastic drop in body temperature a symptom, such as a drop of 10 plus degrees?
No, it is not. Usually when the body temperature drops at that certain degree, it could be a sign of what we call a sepsis or infection in your system. Again, I'm just talking in general. I'm not saying any specific case. Normally, when the blood pressure drops, and you also go through some other symptoms like having fever, very lethargic, not waking up, very confused. These are the constellation of symptoms for the sepsis or the infection in the blood, but not for the stroke.
Okay. Now it looks like we have more questions in chat, so let me switch over.
Sure.
Let's see here. Do you have participants on automatic mute? Oh, goodness, that's not a question for you. Let's see. Let me scroll through. One of our participants said this is a very good plethora of information. She says she's truly learned a lot of important health factors and information and wants to thank you for sharing your knowledge and education.
My pleasure. Thank you.
Oh, you're getting a lot of thank yous, a lot of thank yous.
Oh, thank you. Thank you.
Any sources for the uninsured for access to healthcare in the DFW area, specifically Garland?
I'm sorry, I don't know, but we from the Baylor Scott and White, we have a clinic in the downtown hospital run by our residents and the physicians. It's a charity clinic, if I believe. You can get that information from our website, Baylor Scott and White, and I'm pretty sure that there is a clinic, but I don't know in details about their contact info, but it is in our website. Or you can call the Baylor Scott and White downtown hospitals and they can give you that information, I believe.
So one of our participants says that her husband had a cardiac arrest and a stroke, separated for about 7 years. Mm-hmm. He has been on Eliquis since the stroke and is anticipating a hernia repair surgery soon and has been told he could stop the Eliquis a couple of days before, but he's concerned of a blood clot. Is there an alternative to completely stopping the Eliquis? And is there some injectable bridging treatment for the days prior to surgery?
Yes, there is a bridging treatment for the surgery, but when this type of cases, we need to take other things in consideration, like as you mentioned, that is, I think he mentioned the 7 years of treatment of Eliquis, all right? If it's been 7 years on Eliquis and never had any stroke in 7 years, that indicates that the stroke risk for him is low. And in that case, if surgery is needed and indicated, then yes, you can stop the Eliquis and get the surgery without any bridging. But having said that, anytime you stop the medications, Eliquis, there is no guarantee that you will not have a stroke. And at the same time, there is no guarantee that you will have a stroke. But again, as I said, it depends on the overall the condition. And if he has not had any stroke, has not had any stroke in the last 7 years since being Eliquis, indicates that it is a low risk for stroke, and in that case, I think it is safe to stop. But say if he has been on Eliquis and he still had few more strokes here and there, that indicates that maybe he's at high risk, and in that case, we may need to bridge him with this the medicine prior to the surgery. The one thing is when you stop the Eliquis, it will be still in your system for 48 hours. Okay, so at least 2 days prior to the surgery, it needs to be completely stop the medicine, then bridge with the IV medicine what we call the heparin, and then get the surgery. And after the surgery, and it also depends on what type of the surgery, how long he needs to be off that medicine. Some types of surgery, they can even restart the medicine the same day or the next day, but the other types of surgery, they may need to wait for another couple days. So you need to take a consideration of all these things to make that decision. But yes, there are both options there. It depends on the risk. If you think, or your doctor thinks, that it is safe only to stop, get the surgery, and we can restart the medicine after next day, then you do not need bridging. But if it is a higher risk surgery and you need longer, then you may need bridging.
Okay. If your blood pressure is controlled with medication, will this prevent a stroke?
Absolutely, yes.
If you are taking blood thinner, this person has been taking it lifelong, what are the chances of you getting another blood clot or having a stroke?
So the good questions, the blood thinner is actually, if you are taking the blood thinner because of atrial fibrillation. So there are very few conditions that we require actually a blood thinner to prevent the stroke. So if that is the case, then your risk is actually, with this blood thinner, we reduce the rate 66%. With only aspirin, if you have an atrial fibrillation, and if I put you on aspirin or Plavix, I can reduce your risk 23%. But with the blood thinner, I reduce your risk of 66%. That's almost double the risk we can reduce. But if you pay attention that 66% is reduced, means you still have high chance of having the stroke or the blood clot in your brain. But we do not have any other medicine to further lower this the risk. So yes, you are not 100% immune, but this is the only medication we have in case of atrial fibrillation and stroke to bring it down. And honestly speaking, the risk is, in general, in practice, we don't see patients coming back too many cases when they are taking blood thinner religiously, without very compliant. So I think you are pretty safe as long as you keep taking the blood medicine. But remember, the blood thinner is preventing one type of stroke, and that is because of mainly the atrial fibrillation. But if you have concomitant, or if you have concurrent high blood pressure uncontrolled, diabetes uncontrolled, that can cause a different type of stroke that does not any relationship with the blood thinner. You still can have stroke if you blood pressure is uncontrolled, diabetes is uncontrolled, if you continue smoking. So that is how you have to understand the future stroke being on this blood thinner.
Dr. Hasan, can you talk to us about statins?
So the statin is definitely recommended once you have a stroke or any heart disease. Initially, we were looking for a number. You know that there are two types of cholesterol. One is called the good cholesterol, and one is called the bad cholesterol, or LDL. So for the bad cholesterol, we were looking for the bad cholesterol number to bring down to 70. Okay, once you have a stroke or a heart disease, then we want your LDL number to be 70. But recent recommendation has changed, and we are saying right now that we should not look for that number. We should keep the patient on statin lifelong once they have a stroke. But if their cholesterol remains stable or below the goal of 70, then we can at least continue a low dose statin rather than the higher dose. So based on that number of the cholesterol or LDL, right now we decide whether you would be higher dose or the lower dose, but you should not stop it completely.
Okay. Well, Dr. Hasan, that was a lot of questions, and thank you so much for your responses. Do you have any final thoughts that you would like to share with our audience today?
Yes, absolutely. Again, just want to emphasize that please do not delay the care your loved one needs because of only the pandemic. If you suspect that they are having a stroke, or even not necessarily only a stroke, a heart disease, an infection, an abdominal surgery needed, or something like that, do not hesitate, because again, all our healthcare facilities nowadays, at least, we have enough PPEs, we have enough measures taken to prevent the contamination and prevent this transmission. But rather, we need to save the brain, we need to save the heart, and we need survival. Because think about it, if you are worried about getting the transmission of the COVID and staying at home, and unfortunately your brain cell dies, then it's also, you could suffer rest of your life. So please bring your patients or loved one to the hospital as soon as possible. And thank you everyone for joining and participating. It's really make us happy when we see our community members are engaged in this kind of an educational program.
I'll share one last comment that I see on chat. It says, Dr. Hasan, thank you for this information. It's awesome. Please do these more often. So that's what we want to hear. Thank you.
Yes, thank you.
So we do have one last little tidbit of information for you, and that's strokequiz.com. We encourage you to visit that website to assess your risk for suffering a stroke. Remember, as Dr. Hasan mentioned, understanding risk factors can lead you to make healthy changes to help prevent a stroke. And while some factors are permanent or hereditary, there are lifestyle changes that you can make to lower your risk. So take the first step towards a healthier you by learning your risk at strokequiz.com. And we have, there it is on the screen, you need to write that down. We have come to the end of today's presentation, and our goal was to arm you with all the knowledge you need to take charge of your health and make sound decisions. So with that, I want to thank Dr. Hasan again for providing us with the tools and information for us to be able to do just that. And on behalf of Baylor Scott & White and Dr. Hasan, I want to thank you all for your participation. Thanks so much.